Okay, so it is 12 o'clock, so we'll go ahead and get started. Good afternoon, everyone. Thank you for joining us today. My name is Katrina Hernandez, and I'm a behavioral health consultant with OPEN, the Overdose Prevention Engagement Network. We welcome you to today's webinar, Unlocking the Use of Ketamine in Patients that Use Non-Prescribed Substances. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenter. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and hit send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME, Social Work CE, and McBack credit for today's webinar. We'll have a slide up with information about obtaining these credits during the Q&A portion of the webinar. We will also email the continuing education credit information after the webinar today. We have no disclosures, and as I mentioned, the CE information will be posted at the end of the webinar. The Overdose Prevention Engagement Network, OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative, evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts who provide guidance for managing patients who have substance use disorders or complex pain, and who can answer both individual treatment and technical assistance questions. We offer expert-led education and training sessions. Many of our webinars offer free CME, CEU, and McBack credits, and for prescribers, all our credits also qualify for the DEA required SUD training. We provide MOUD trainings for providers, and this year we are incentivizing primary care providers and APPs with $250 to complete one of our MOUD trainings. We hope this encourages confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing. OPEN also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable educational materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. Provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication storage and disposal options. We assist groups all across the state in hosting local medication take-back events. We fund implementation of permanent medication disposal boxes for qualifying applicants, and we provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. We offer overdose rescue support. We fund implementation of naloxone vending machine and distribution boxes. We also offer naloxone administration training. These trainings are offered in person or virtual and are free. You can access more information about all of these services more directly using these QR codes or by visiting our website. OPEN understands that effectively addressing OUD and other substance use disorders requires deep collaboration and tailored solutions to meet the unique needs of each part of the state. Our behavioral health consultants work directly with physicians, physician groups, and community organizations in your area to help build connections and networks locally throughout the state of Michigan. Our presenter today is Dr. Menke. Dr. Menke is a clinical assistant professor at the University of Michigan Medical School. He is board certified in addiction medicine, emergency medicine, and medical toxicology. Dr. Menke joined the Department of Psychiatry at the University of Michigan in 2021. He cares for patients suffering from substance use disorders and in the inpatient setting as part of a multidisciplinary team. The inpatient addiction consult team initiates and titrates medications for opioid use disorder, manages withdrawal from opioids, alcohol, and benzodiazepines, treats pain in patients with tolerance to opioids, and helps connect patients to drug and alcohol treatment. Thank you again for being here today, Dr. Menke, and I will now turn it over to you.
So today I'll be talking about ketamine and kind of the new research around the use of ketamine in substance use disorders. And this is a topic that I love. Ketamine is one of my favorite drugs to use in the hospital, and this is a passion project for me, I guess you could say. So I have no financial disclosures, but I will be discussing off-label use of ketamine in this talk. And so ketamine is not a new drug, right? It's been around for 50 years. It's a derivative of PCP, right? So they were looking for a different anesthetic agent for patients in the OR. And PCP had some significant adverse effects that made it unsuitable for use in anesthesia. And so they did a derivative of that, which has a ketone group adjacent to an amine group, hence the name ketamine. And I've been told that it's supposed to be ketamine because it's a ketone and an amine, but I still prefer ketamine as a pronunciation. But people may tell you you're pronouncing it wrong, but that's how I prefer. And so ketamine was safe, and it didn't have the issues that PCP did have. So it was approved by the FDA in 1970 for use in the OR. And so again, that's 50 years of FDA approval for this drug. And so it's just in a class. This is the boring pharmacology stuff. I'm a toxicologist, so I have to talk about this. So it won't hurt my feelings if you ding me for the dry pharmacology portion, but I feel obligated to talk about this. It's in the cyclohexamine class. It's got two enantiomers, the S and the R. S is the more active one, and that's what S-ketamine is. It's available IV and IM. If you give it PO, it only has about 20% bioavailability, and you generate a lot of norketamine from first-pass metabolism. Sublingual is about 30%. The intranasal S-ketamine is 25 to 50%. Of course, the intranasal is only the S-ketamine enantiomer, so it's more active than the PO and the sublingual at equivalent doses. The typical onset is in minutes, peak is 30 minutes, half-life is 2 to 4 hours. Like I said, the major metabolite is norketamine, and norketamine is active. That's pretty much it for the basic pharmacology. And so, as with any other substance, ketamine has adverse effects. The classic one is the emergence reactions, right? So the patients, when they're coming out of the anesthesia, they describe floating sensations with distortions of body image and objects. They demonstrate acute psychosis, basically, as a result of this drug. And again, this is going to be dose dependent, right? You're more likely to see this with higher doses. Cardiovascular, it does increase blood pressure and heart rate, typically not clinically significant. It has lots of psychomimetic effects, visual hallucinations, vivid dreams. Those are very common. GI at high doses, you can get nausea and vomiting. And then you can occasionally get laryngospasm and hypersalivation, but those are pretty rare. I've personally never seen those in my career. And then when patients use it outside of the medical use, they're using recreational, they're using a lot, they're using daily, there is chronic cystitis and memory impairment has been reported. And it's really only FDA approved for dissociative anesthetic outside of S-ketamine, which is approved for treatment-resistant depression. And so the effects are dose dependent. So at low concentrations, it's psychomimetic effects. So you get the hallucinations, feeling of detachment, distort perceptions of sight and sound, right? This is why patients are using it in a non-medical environment. This is the effect they're going for when they're using this at raves or at home. But as you increase the dose, you get sedation, you get decreased sensory experience, you get unconsciousness. But as opposed to other anesthetics, like the halothane or propofol or anything along those lines, you don't get significant respiratory depression. So patients are able to maintain airway tone and respiration. And this is why ketamine is used on battlefields. It's used in like third world countries where they don't have an anesthesia machine, but they need to do an operation. It's used by EMS because it's so safe and works very well. It also causes anti-nociception, causes insensitivity to pain for patients. And then, like I said, it does increase heart rate and blood pressure due to increased sympathetic activity. And so, what is it being used for now? So, procedural sedation, right? I don't know how many doses of ketamine being given in the ER right now across the country, but it's a lot. And again, it's got this airway protection and anti-nociception. So you're able to do procedures like reducing dislocations, reducing fractures safely, and with pretty much no discomfort to the patients. It's being used for acute and chronic pain in many, many places. Again, treatment-resistant depression, many places have IV protocols, including the University of Michigan, for the treatment of depression. And again, that's off-label use because the IV formulation has not been approved for that. The S-ketamine, again, the intranasal formulation has been approved. But if you're using an IV or PO or sublingual or IM, that's off-label use. Psychiatry is looking at it in anxiety and PTSD. And we're starting to look at it more and more for the treatment of substance use disorders, especially those that do not have good treatments at this time. And then again, obviously, patients are using it for the effects you get with it. And again, when you talk about ketamine, you have to talk about the dose you're using because the dose tells you what the patient is likely to experience. And so when we're using for pain, so again, at the University of Michigan, we're using doses from 0.1 to 0.3 milligrams per kilogram. So in a 70 kilo patient, the average number we use, it would be 7 milligrams an hour. And those patients are not experiencing any of the psychomimetic effects. I mean, most patients can't even tell it's on. Once you start getting up to 0.3 milligrams, sometimes patients do start experiencing the psychomimetic effects and they feel weird. And sometimes we have to have to drop it down to 0.2. But that doesn't happen very often because typically you don't see the real dissociation, the partial dissociation, till 0.4 mg per kg. And then when you're talking about depression doses, the classic treatment is 0.5 mg per kg over 40 minutes, right? So it's that total dose over 40 minutes. And again, UM's policy is they will go up to 1 mg per kg, depending on the patient. And again, that falls into the partial dissociation. So those patients will have significant psychomimetic effects that you can anticipate, and you need to counsel patients prior to giving it. Once you start getting over 0.7 mg per kg, you're getting into like full dissociation, 0.7, 0.8 mg per kg. And then 1 to 5 mg per kg is the anesthetic doses. And then what the patients are using doses 0.7, 0.9, right? That makes sense. They're looking for that partial dissociation effect. They want those weird feelings. And, they don't want to go higher because you don't want to be unconscious. You're not spending money on substances to be knocked out. You're doing it for an experience. And you get that experience at the partial dissociation. And this talk isn't about pain and depression, right? Those are kind of separate topics, but there is an enormous amount of literature regarding these two topics. I'm talking like greater than 4,000 PubMed citations. And for pain, it's been used for perioperative pain, acute pain, chronic pain, neuropathic pain, pain in patients that are opioid tolerant, whether it's prescribed or not. We use it all the time for burn patients. And these effects from the pain dosing typically last 1 to 2 weeks after the infusion. Same with the treatment-resistant depression. Again, there's thousands of PubMed citations, and all of them generally show the same thing. So it's not the same issue we get with like the AUD medication literature, where you have a very small treatment size effect. So you have some positive studies, some negative. These pretty much all the studies demonstrate the same thing. And again, the pain literature, I'm not going over all the literature, but it works really, really well. And again, the doses we're using for pain are sub-dissociative. We're not getting over 0.3 mg per kg per hour. So these patients are awake and they're usually not having psychomimetic effects. It's not through the opioid receptor. So even if patients, again, it's a benefit for the opioid tolerant patients that you're not using that receptor, you're using a totally different pathway to provide analgesia. It's been shown to decrease opioids when you use it for patients going to the OR or for other acute painful episodes. It's been used in the ERs, ORs, on the floor. Again, there's studies of ketamine used everywhere. And it has some really nice effects that for some patients that are suffering from hyperalgesia, the most common one being opioid-induced hyperalgesia. But we have definitely used it for patients with other types of hyperalgesia from central sensitization that it works for. And then it's thought that due to its mechanism, it may prevent the wind-up phenomenon, which is kind of a pain stacking. So the more you activate the pain fibers, the more they fire and the more intense the sensation is. And then central sensitization is just this different type of pain where the pain signaling is abnormal. And so classically what I think about when I think about a central sensitization is a patient with fibromyalgia, right? They have pain everywhere. And the main reason they're having the pain is because their body's no longer processing pain normally. And so they have an amplified pain signal. And ketamine is thought to prevent that from occurring. Again, you have lots of patients post-surgery that develop chronic pain from this abnormal pain pathways they develop in their brain that leads to chronic pain even after their acute surgical wound has healed. And there's no functional cause of this pain. It's all due to abnormal pain signal. And again, the depression literature, again, there's no argument with it. Patients feel better who are depressed on ketamine. And again, it's pretty much, I'm not sure it's been studied outside of treatment-resistant depression after they've failed, antidepressants, because this is not my field, but it works very well. And again, the other argument of how a drug works is because it's dose dependent, right? So if you give a little dose, it works a little. If you give a higher dose, it works better. And that is an argument that the drug is doing something. So if you do a dose range and that you get the same effect on all doses, you have to be suspicious that the drug's not working that well or something else is going on. But in ketamine, you definitely see a dose response. Typically, patients do better on higher doses. Obviously, they're going to have more of the effects, right? For the depression, we talked about 0.5 mg per kg over 40 minutes. And at the University of Michigan, they're usually dosing it a couple times a week. I think the maximum is 3 times a week. And they usually do it over a month. So you're talking, 8 treatments over a month. And that the IV ketamine works better than the intranasal S-ketamine. Again, that's more argument regarding the dose effects of the drug. And, there's debate about whether the psychomimetic effects are what's causing it. But again, the correlation between its antidepressant effect and the psychomimetic effects is only about 40%. And the other nice thing is that it decreases suicidality. So there's some talk of maybe in the ER for patients who are suicidal, being able to give them a ketamine infusion as a stabilizing factor, rather than necessarily having to admit them to the hospital, that you can make them feel better for at least 2 weeks, right? We talked the treatment effect is about 2 weeks so that you have a chance to work a better outpatient plan for the patient. And so how does ketamine work? And this is not a question we have an answer to. So we know it's an NMDA receptor antagonist, and NMDA is the main neuroexcitatory receptor in our brain, right? So it hyperexcites our brain. And so this drug blocks that. But it does other interesting things. So for example, it decreases GABA, and GABA is our main neuroinhibitory neurotransmitter. And so it blocks the presynaptic GABA so that more glutamate is released, but it blocks the effects of the glutamate. So you have more glutamate in the synapses, but it's not activating things. So it's kind of just a weird drug. And again, we're not cutting people's brains open and examining how they're working. So all this is hypothetical stuff. But the NMDA receptor antagonism is likely the reason why it's a dissociative anesthetic, right? That's the main mechanism. Now, the other things we talk about, the depression and analgesia, it's likely to be more complicated than that. And it has been found to antagonize other receptors. So nicotinic, muscarinic-cholinergic receptors, it blocks sodium-potassium channels, it activates the D2 dopamine receptors, activates some calcium channels, facilitates GABA receptors, enhances descending modulatory pathways. And so because it does so many things, it's hard to pin down exactly what part of that is causing the effects, for example, the depression and the pain relief. And so again, mechanistically, it doesn't really matter at this point why it's working, because we know it works, right? We know it is having an antidepressant effect. We know it has an analgesic effect. We know it causes psychomimesis and it causes hypnosis at high doses, right? The dissociative anesthetic. And which of these correspond to which of those effects, again, is not known. And one of the most interesting things about the drug is that we have prolonged effects, right? We give a single infusion of a medication, and 2 weeks later, it's still having an effect. So that is not due to receptor activation or blockade, because the drug's gone, right? Pharmacokinetically, we know that drug has been metabolized and it is not in your body, but it's still having an effect. So that means it's not receptor activity that's causing these prolonged effects. And so the hypothesis is that it's affecting synaptic plasticity. So it's able to affect the connections between the neurons and how they're activated. And so synaptic plasticity is integral to the learning process. And so if that becomes altered, we see diseases such as depression, stress, addiction. It increases neurogenesis. And again, we know that is a problem in depression, is that the lack of neurogenesis is something we need to address. And it likely affects functional networks. And what that means is just how these neurons are interconnected and how they work together to do functions. And again, these are thought to be crucial in these diseases that we think ketamine works for: addiction, depression, PTSD. So that is kind of the current theory on why we're getting the prolonged effects, and why it's affecting these things. Again, it's debatable. Some say it's, the NMDA blockade causes a change in the secondary messengers, and that's causing the neurons to behave differently. But no one can give you a real answer. We just know it's doing things that help, and we think this is why. And so you think about how SUD compares to clinical depression and stress disorders, which we're pretty sure ketamine works for, right? And so they share a lot of the pathophysiology, right? Substance use disorders are a brain disease, and the type of brain disease is very similar to these stress disorders and depression, right? It's alterations in this synaptic plasticity in these functional networks. It's neurogenesis. The BDNF is responsible, or at least partially responsible, for neurogenesis. And this abnormal neural connectivity that we talk about when we talk about the neurobiology of addiction, right? So it's not surprising that if it works for depression, it's going to work for substance use disorders. Additionally, almost all of the patients we see in the hospital have comorbid psychiatric illness. And again, is it primary, is it secondary, the substance use disorder? But with ketamine, it doesn't matter, right? You're treating both, you're treating one, it doesn't matter, because you're providing treatment for it, again, and that's the beauty of it. And oftentimes our patients really struggle even post detoxification, right? You talk about the acute withdrawal and then subacute, and how do patients feel during the subacute withdrawal period? They feel terrible, right? They're dysphoric, they can't get out of bed, they sometimes have to return to use in order to become functional again. And if ketamine can prevent that from happening, that would be another method by which it would help patients maintain abstinence, if you're able to get them through this post-acute withdrawal period where they feel terrible. And so when you start talking about studies of ketamine, some of the early ones were on the physiological response to opioid withdrawal. So this was a study that they did. It's one of those rapid detoxifications where they intubate you, they put you on general anesthesia, and they hammer you with naloxone. Right. So in this case, they gave ketamine for 22 patients and none for the control. And they saw a significant decrease in the physiological response to naloxone in the patients on ketamine. They saw decreased cortisol levels. The control patients required much higher levels of anesthesia. So there is definitely evidence that it does ameliorate the physiological effects of opioid withdrawal. And a lot of people are starting to use ketamine to initiate patients on buprenorphine who are using fentanyl, because again, the risk of precipitated withdrawal is so high that patients have to wait, 4 or 5 days off fentanyl. And again, that's a huge barrier to being able to start buprenorphine, that either you're going to make them sick or they have to wait that long. And that's really challenging for our patients, especially ones injecting fentanyl. Like, it's just not a reasonable expectation. And so if you could give them ketamine prior to each dose of buprenorphine, you could decrease this physiological response to precipitated withdrawal, and you could start them sooner and they would do better. And that is likely happening. Now, the extent at which it works, I think, is debatable. Like when you hear the people talking about it, they say how wonderful it is, and it suppresses all symptoms. And again, that's not been my clinical experience. Patients feel better on ketamine, but it does not stop withdrawal. They just still feel not great. Right. So the next one is alcohol use disorder. And so we don't really talk about ketamine for the treatment of opioid use disorder because we already have treatments, right? We have 3 FDA-approved medications, and they all are relatively efficacious. So it's not as needed for treatment of OUD. It is needed for the treatment of withdrawal and the pain associated with it, but it's not really that needed because we have good therapies, as opposed to alcohol use disorder, where the 3 FDA-approved medications, like camprosate, naltrexone, and disulfiram or antabuse, they just don't work that well, right? There's lots of studies that demonstrate some effect in some and no effect in others. So they likely have some effect, but the treatment effect is small relative to methadone and buprenorphine. And the number of patients with alcohol use disorder vastly outweighs the number of patients with opioid use disorder. And the number of patients dying from the chronic effects of alcohol is still higher than the number of dying from opioid overdoses. Not to mention all the patients with morbidity of liver failure and requiring liver transplant and that type of thing. And so it has been looked at in alcohol use disorder, and there's about 7 studies the last time I looked. And again, these studies are not homogeneous. They're very heterogeneous about which patients you're choosing, how long you're studying it for, how you're measuring alcohol use, that type of thing. And typically all these studies are doing IV or IM ketamine. And typically it's something along the depression type of protocols where you're getting an infusion over an hour, and then you repeat that maybe 1 or 2 times, just depending on each study. But it definitely demonstrated effect. And again, all the studies just demonstrate similar effects. So it's not like some are positive and some are negative. They're all pretty much showing the same thing. The patients have more abstinence and reduced alcohol consumption and cravings. And in addition to how we talked about the general effects of ketamine on substance use disorders, the change of brain function, it would, in theory, work even better for alcohol use disorder, because alcohol doesn't just affect the GABA receptor, right? Again, we said GABA is the main neuroinhibitory neurotransmitter. So alcohol is a depressant and affects that neurotransmitter. Same neurotransmitter, or same receptor as benzodiazepines. But it also affects the NMDA receptor, right? We talked about that's the main neuroexcitatory. So it blocks that one. So you have increased inhibition and decreased excitation, right? And that's how alcohol provides its effects. And so because ketamine affects the same receptor as alcohol, it's likely to help these patients more, right? They talk about a camprosate that may be an NMDA receptor antagonist, and that may be why it decreases urges and cravings. Again, it's all theoretical. But it makes sense that if you maintain that receptor activity that you're getting with ethanol, they're less likely to return to use. And it has been shown to be in alcohol withdrawal in a few studies. There's only 3, and 2 of them are from basically the same patient population. But they did decrease ICU length of stay, decreased intubation, and decreased the need for benzos and phenobarbital. And again, this is something I use clinically, and I think it works personally. And I was on one of these studies, so I am biased. But again, we did it because we thought it worked, and it seems to work. So another drug that we don't have many treatments for is cocaine, right? So there's everything has been tried, and again, the treatment size effect for anything is going to be really small if it does work, based on the studies we've done thus far. So if we have a treatment like ketamine that can change their brain making it more functional, that would be great for cocaine. It would be great if it worked for methamphetamine. It would be great if it worked for alcohol, since we don't have great treatments for these. There's only a couple studies so far, and again, it demonstrated that patients did better on ketamine. And again, it's not surprising based on how we think it works. And we know it works in depression. And again, all these cocaine patients, after they've finished their withdrawal, they all feel terrible. And it wouldn't be surprising if that alone was good enough. It's been looked at in cannabis. Again, one small study demonstrated decreased use. Again, all this has to be taken with a grain of salt because it's been so poorly studied. But again, when you're talking about mechanism and how we know it works for depression and pain, it makes sense that it will work for substance use disorders, and is definitely something we need to study. I think about it similar to how I think about LSD and psilocybin. Those probably work in a very similar mechanism as ketamine, but we don't have great data demonstrating it. I mean, we have a lot of small studies, but again, those medications are Schedule 1, so they're really hard to do testing on. Ketamine is a lot easier to do clinical studies because it's a Schedule 3 medication. And so, again, it opens up this alternate pathway of treating addiction that is kind of independent of the drugs and focuses mostly on the brain, which would be great. Similar to how we're hopeful that the weight loss drugs, because they're affecting the reward center, will hopefully provide another alternative way of affecting patients' brain independent of the substances they're using. And so, based on literature, I suspect that ketamine will be demonstrated to show that patients are able to establish and maintain abstinence better than being off it. It's probably going to help with cravings, motivation to quit, helps decrease use, and then it more than likely does reduce the physiological response for opioid and actually alcohol withdrawal as well. So it is very hopeful that ketamine will provide us another treatment modality for these patients that have a terrible disease that we have minimal treatments for. We just tell the cocaine patients you need to go to treatment, but again, that's oftentimes challenging for patients. If we had a medication that worked, that would be great. Now the question is, how do we get this to patients? And so that's part of the big problem. So it's a Schedule 3 drug. So anyone with a DEA that can prescribe Schedule 3 can prescribe it. It is off-label for these indications, but pretty much, I can't remember what it is, but it's like 20% of all prescriptions are off-label. So it's not like you're going beyond the normal practice by prescribing it off-label, because we do it every single day with lots of different medications. But most retail pharmacies do not have ketamine, right? So you have to go through a compounding pharmacy. So the palliative care does prescribe ketamine for their palliative patients, and they go to one specific compounding pharmacy that you kind of need to have an agreement with them, and they will fill these ketamine prescriptions for them. And typically, when you're writing an outpatient script, you write a troche, right? It's kind of how to describe it. It's just this almost like a cough drop type of thing, maybe a little softer, that you put under the tongue, right? So it's sublingual. You could do syrups. People have used ketamine for topically in a cream formulation. People have used it for oral washes for mucositis. So there's lots of different ways you can compound it, but the classic one is the troche that is administered sublingual. And again, we talked about the bioavailability being about 30% for such formulations. And then in theory, if your clinic is able to administer drugs and you have the all the FDA requirements to have scheduled medications in your clinic, you could administer this IM to your patients. Now, I'm not saying that's a great idea. I'm not saying you should do that, but it is not illegal, right? Again, you need to look at your local regulations to make sure you're allowed to do such things, but there's no reason you couldn't do it. And then the last way I didn't put up here is the ketamine infusion centers. And, you'd have to find a local one. And again, those are cash pay and they're pretty expensive. But that is a way to get ketamine infusions. And so again, does have a ketamine infusion clinic. So you could come here, but it's, again, you have to be seeing a psychiatrist and you have to meet all these criteria. So you would have to look for your local, psychiatrist to see if they're involved in giving ketamine. And so the place they do it here is the same place they do the ECT. So it's in the hospital, but it's technically an ambulatory setting. Because again, ketamine is so safe. Like these infusion clinics, you have people just sitting in reclining chairs with minimal monitoring. Because again, it's way safer than giving patients opioids. It's safer than giving them benzos. It's safer than almost any other medication we give. The adverse effects are so rare, and they're not usually dangerous when they do occur. And so how do you pay for these, right? Insurance is not going to cover it. It's just exceptionally unlikely. I would be super surprised if any insurance company ever paid for ketamine. So how much does it cost? So if you're talking about using it for pain, you're talking about a dose of 30 milligrams sublingual TID, which, that's 90 milligrams total per day. So that's usually a little over a mg per kg for patients. It's about $100 per month. If you're using it for acute withdrawal, typically what you're doing is you're doing doses of like 8 milligrams, maybe as high as 16 milligrams. The clinics that are doing it are typically dispensing about 64 milligrams total to patients. And that typically costs around $10. And this is for those buprenorphine micro initiations that patients are doing at home. So they'll write them a script for both the buprenorphine and the ketamine. They'll tell them, take 8 milligrams of ketamine an hour before your buprenorphine. And then if you feel symptoms of withdrawal after that, then you increase your dose to like 16 milligrams of ketamine. They typically say, try not to go above 32 milligrams in like a 6 or 8 hour period, because you're going to start getting pretty significant psychomimetic effects. And that's not what you're going for when you're using it for withdrawal, right? You're just trying to dampen down the physiological response. Some clinics have said they found funding through their own clinic. Some have applied for grants to pay for medications, including ketamine. But again, this is a barrier oftentimes for our patients. If they can't afford it, they can't afford it, assuming you can even find a pharmacy that's willing to compound it for you. And then the next thing we always have to talk about is the use of a medication if we end up prescribing. And so the classic, again, is the opioid epidemic. If you prescribe doses, then they will be used. And whether it's by the patient you're prescribing it to or someone else, it's going to happen. And so we saw this epidemic of opioids once we started significantly increasing our prescribing. It was associated with increased OUD, increased overdoses. We saw a similar thing with gabapentin. The more it was prescribed, the more we're seeing it in patients' autopsies of patients that overdosed. Similar to how we're doing Adderall. The more you prescribe Adderall, the more it's going to be used. And so one of the concerns about starting to use ketamine for the substance use disorders are the non-medical use of it, because it's going to happen, right? If you write a patient 64 milligrams of ketamine to go home with to treat their withdrawal, not all our patients are going to use it, and some are going to sell it or give it to their friends. But again, if they do use it, they're not going to overdose and die. And, a lot of people have used ketamine, but the prevalence of ketamine use disorder is really pretty rare. Like there isn't even much data on it because it's just not that common. It's more likely to be in like Hong Kong, and there was a hotbed for it. They've done studies on that's a lot where the chronic cystitis was described. A ton of MVCs have had patients on ketamine. So it can definitely happen that ketamine can cause use disorders, but it's a lot less dangerous, again, than opioids or benzos. I'd be much more concerned about writing a patient a benzo than ketamine. And you talk about patients wanting to get intoxicated from ketamine. Well, again, the type of intoxication you get from ketamine is this like dissociation. So only a specific portion of patients are going to want that. And, it's just not that addictive compared to opioids or, again, benzos or meth or cocaine. So people will definitely use it. Again, rave culture is a big place for using ketamine, but it's not as big a problem. And again, we don't see much ketamine out here. And again, it's going to be very regional, and it's going to be partially availability, right? If we flooded the streets with ketamine, we would definitely be seeing more ketamine use disorder. So it's something you have to be thoughtful about when you use these medications, is not just the effects on your patients, but the public health implications. And so that's the other thing about the S-ketamine, again, is not likely to be used, or is less likely to be used non-medically because it's under the REMS, right? The risk evaluation mitigation strategy. So it's kind of like the Sublocade, is that these medications are very closely regulated. So it's not likely to be getting out on the street as much. And I've never had any of our patients tell us they were using S-ketamine thus far. And so that's kind of the main talk, is ketamine is safe. It will likely provide an alternate treatment therapy for our patients, especially in those disease processes: alcohol use disorder, methamphetamine use disorder, cocaine use disorder, cannabis use disorder, where we don't have good treatments that's safe and will hopefully, again, provide us an alternate treatment path for our patients. Because again, LSD and psilocybin may also work the same way, but it's going to be a long time likely before those are going to be able to be used as a scheduled medication, right? They're still Schedule 1. So I think we have some time for questions.
Thank you, Dr. Menke. Sarah is going to be posting the chat the information for credits. So you can scan the QR code by using the camera option on your phone to access information about obtaining your credits, or click on the applicable link in the chat. This will also be emailed to all attendees after. So if you are unable to get it right now, you will get an email with that also. So now we do have some questions that were put in the Q&A. So the first question is, how long is the typical ketamine treatment for depression and SUD? Weeks, months, years?
So, I mean, classically, the treatment for depression usually lasts around a month. And again, it's about 2 or 3 sessions per week for that month. SUD, there's no good numbers for it, but I would, again, likely it'll be the same as the depression. So it'll be probably about a month, where you would anticipate the treatment effect is going to be at least 6 weeks from that. And that would, again, will get you through the post-acute withdrawal period for patients. If you can get patients 6 weeks abstinence, that's a very good starting point.
And do we know?
I'm sorry, so there are no real protocols for SUD. These are all based on research studies. The depression, there are lots of protocols. And again, I'm just going by the UM.
Thank you. Do we know the impacts uses of ketamine on people with stimulant use disorder, which has no current standard treatments? I know you briefly touched on that in the presentation.
So again, there's just 2 small studies with cocaine. And again, I'm just hopeful that it will work for cocaine and amphetamines, but there is no good data.
And do we know the impacts uses of ketamine on people with co-occurring use disorders?
So no, so we don't have a good answer to that. But again, so we use ketamine all the time in the hospital, like daily. And our patients really feel like they're benefited from the effects, and they're not having dissociative effects. They just feel better. And so again, I'm not that concerned that our patients are going to go out and start seeking ketamine. We did have one patient who did, out of all the patients we've treated, and we've treated hundreds of patients. But again, it's not something I really worry about, especially when you're comparing it to what we're treating. So when you're talking about harm reduction, if you're talking about someone using ketamine versus cocaine, I'd much rather they use ketamine. And when you're talking about combined overdoses, ketamine does not cause respiratory depression. So it should be relatively safe when you combine with opioids or benzos. There shouldn't be synergistic effect in respiratory depression. Now, it does cause increase in likely catecholamine release. So if you combine it with cocaine or meth, there could be the potential for worsening of sympathomimetic toxicity. Again, there's no studies for that, but that's just how those drugs work.
Thank you. Where are the places in Michigan that provide ketamine treatment?
So again, there's ketamine clinics, and you'd have to just Google your local area. And then there's psychiatric places that will do the ketamine infusions. And then again, like our palliative care does. So it's going to be very specific providers do it. So the question is, as a PCP or a addiction professional, should you be providing these prescriptions for patients? And that's not a question I can really answer. I will tell you that some people say you should be doing it, but again, the data isn't strong enough that you definitely should be. Right. So, and that is a problem, because you have to go to the compounding pharmacies if you're going to prescribe it. You have to go to an IV infusion clinic, which costs cash money, and it's not cheap, or you have to find a psychiatrist willing to do it. And so those are all not great options at this time. So availability is a barrier to use of ketamine in the treatment of SUDs at this time.
What things should I look for when vetting a ketamine infusion clinic as a resource for care coordination?
So honestly, I would just do cost, right? Because if you're telling your patient, you should be doing, this ketamine treatment, you should be dictating whether they're going or not, right? The ketamine clinic, I wouldn't trust to do that. It should be your judgment. Like, hey, you have a serious use disorder. You definitely have co-occurring depression. I think you might benefit from it. You failed all these other treatments. You failed inpatient. You failed outpatient. Your life is a wreck. Let's try this, right? So you're dictating whether they should get it or not. And I would not rely on the clinic to make recommendations on whether they need further treatments. It was going to have to be your judgment. So if you're willing to make that call, then I would just worry about cost. Because again, it's so safe. Like, they're just, the ketamine infusion clinics are just doing the depression protocol pretty much. They're doing the 0.5 mg per kg over 40 minutes. You sit in a recliner chair. Sometimes they do therapy, sometimes they don't. So I guess that would be the other thing. If you want the patients to have the therapy associated with it, because a lot of these hallucinogens, psychedelics do therapy in conjunction with it. Now, whether you need to do that or not is debatable, and you'll definitely get benefit without it. But that would be, I guess, something else you would look at, is if they provide the therapy with it.
And then kind of with that question, what specific interventions would you be looking to offer in these clinics, the ketamine clinics?
Specific interventions? I mean, besides the infusions, I'm not sure I understand that question. Like, I mean, it's the ketamine is the main driver. And then if you want to add the therapy to, it's just a question whether you think they would benefit from the therapy portion too. And so imagine if I had a magic wand and I could create an SUD clinic. Again, I would set it up just like we do our depression clinic. It would be, twice a week infusions of the 0.5 mg per kg, maybe go up to the 1 mg per kg over 40 minutes. That would be my protocol if I were to create one right now.
What dose ranges have been used for alcohol use disorder and meth use disorder?
So no studies with meth. The alcohol use disorder, they're typically doing, a lot of them So the IV ones, they're typically doing 0.5 to 1 mg per kg per hour, right? So they're doing, again, more like the depression doses, but they're also ones where they're doing IM. And when they're doing IM, they're typically just hitting them with 2 mg per kg or 2.5 mg per kg, something along those lines.
Okay. And does the 1 to 2 week duration apply for pain management indication as well? If so,
Yes.
how long should the infusion last?
So again, the infusion, you can just use the depression protocol, right? If you're an inpatient at the University of Michigan, you get the 0.1 to 0.3 mg per kg per hour for 3 days. But there are studies that demonstrate if you just do the single infusion, you're going to have benefit for weeks. So it, and the benefit it does decrease over time, but it's still there weeks later. So if again, it just depends on what you're treating. So if you're treating something like complex regional pain syndrome, they're not, one dose of ketamine is not going to fix them, right? You're likely going to need multiple in addition to the physical therapy and all the CBT and all the other treatments you want to do for that. But if it's someone's with acute injury that's going to be better in 2 weeks, you likely only need one infusion.
Are there therapeutic effects for ketamine used to treat SUD similar to those cited by folks who microdose psilocybin or LSD?
That's the theory, right? So the theory is that these compounds are changing your brain in a way that is therapeutic for patients with substance use disorders and likely depression, right? And it's the same. I shouldn't say that. It's likely to be the same. We don't know. We don't know how these compounds are changing the brain. We have guesses, and the guesses line up with the pathophysiology with depression, and they line up with how psilocybin, LSD, ketamine work. So in my opinion, they're likely the same.
Has ketamine been used to help assist someone tapering off Suboxone?
Tapering off. So I am not aware of people doing that, but it wouldn't hurt. I mean, if you're doing a really slow taper, you shouldn't need, they shouldn't be having significant opioid withdrawal syndrome. If you had to do a crash taper, it wouldn't be a bad idea. Again, you're going to dampen down the opioid withdrawal symptoms, right? That's what it's doing. The buprenorphine also provides, improved mood from the kappa antagonism, or, being the theory. So the ketamine could take the place of that during, again, you may have some dysphoria post taper, just like any other opioid. So it might help with that, but there are no studies with that. I don't know anyone who's doing that.
In terms of ICD-10 diagnosis, would ketamine dependence fall into F16-2? It's rising issue amongst young people and children in UK, mainly taken orally and nasally snorted with minimal to none pharmacological intervention options to treat this dependence.
ICD-10 codes that well. I suspect, I mean, if I were trying to code, I would probably do under like hallucinogen, not specified. I don't know if there's a specific ketamine diagnosis.
Please share some light on treatment options. It's highly debilitating addiction as observed.
So again, I mean, if you're talking about general SUD treatment, again, I just think of it as there's 3 umbrellas, right? There's inpatient, outpatient SUD treatment, there's medications, and then there's the fellowship groups, right? AA, NA, Dharma recovery, smart recovery. So I kind of classify all treatments within one of those 3 buckets, and ketamine would fall among the medications for treating, MAT, as I call it, medications for addiction treatment.
Okay. And someone asked for the contact info for the U of M pain clinic using ketamine.
So I'm not sure our pain clinic doesn't do IV infusions. They only do it from inpatient. So our acute pain service only does it for acute pain indications, typically post-op. They will sometimes do it for neuropathic pain. On rare occasions, they'll do chronic pain, but it's inpatient. Our psychiatry department does do ketamine for depression. And I'm not sure how you contact the clinic.
I put the link in for the palliative outpatient.
And then palliative can do it as an outpatient, but again, they're mostly going to be seeing cancer pain patients.
Thank you. You mentioned that ketamine relieves effects of opioid withdrawal and has pain management qualities, and spoke to its use with naloxone and buprenorphine. So I don't know if they just want you to touch more on that one, maybe.
Yeah, I mean, again, when you're talking about acute opioid withdrawal, what are patients complaining about? Right? They're complaining about abdominal pain, bone pain, complaining of diet, restlessness. And then you have the physiological responses, the yawning, the tearing, the nausea, the vomiting, the diarrhea. And so it's just thought that ketamine dampens all those physiological responses and it provides mood elevation. So again, that's how it's thought to help with opioid withdrawal.
Could you speak to how ketamine can be used instead of or in conjunction with methadone?
So I guess the best way, so the other thing ketamine does that I didn't really speak about is it decreases opioid tolerance and it decreases the hyperalgesia, the central sensitization. So if you imagine a patient using IV fentanyl who gets put on 40 of methadone, it's not equivalent, right? So if you add ketamine to that, you're much more likely to have an effect from methadone than without it, especially at those doses. So like a classic example would be a cancer patient on super high doses of opioids. You add ketamine and now you can drop the doses in half down to a quarter. And it's the same thing for a fentanyl patient, right? If they're using IV fentanyl and their OMEs are 1,000, if you could decrease that, down to a quarter their need and then add methadone, you're more likely to have treatment effect. So you can think of it as making methadone and buprenorphine more efficacious is the theory. Now, whether that's 100% true or not, again, there's no data behind it. This is just people's opinion and how they've seen it work in the patients. So oftentimes that's what we do in the hospital. If a patient is on fentanyl and we're starting methadone, we're starting buprenorphine, we're also doing PO ketamine typically. And we think it does help, but again, I can't prove that.
Can you speak about cases where ketamine has been implicated in cause of death?
Well, so the most recent one was the Matthew Perry one. Right? And so again, it's unlikely to be directly from the ketamine. Again, he most likely took a high dose, he dissociated and drowned. Right? There's the excited delirium ketamine deaths. And again, I don't think it's related to the ketamine. So when you think about why these patients, and whether you should be even using the term excited delirium is debatable. The ACEP has come out against that. But these patients are typically dying a sympathomimetic type of death where they use some type of stimulant, cocaine, meth, and then they're restrained. And oftentimes they're restrained prone. So now you're hypoventilating and your pH is plummeting and you go into cardiac arrest. And so ketamine may, again, like I said, with combining with cocaine and meth, it may slightly increase your heart rate or your blood pressure, but it shouldn't be clinically significant. And I personally think it's safe. I don't think it's having that significant impact on these deaths. Like, I think they're dying because they're being restrained, and they're dying because they're being restrained face down, and they're dying because they're not receiving proper medical care, right? The EMS is, the police come, put them face down and then call EMS. They get a shot of ketamine and they die. But it's not necessarily ketamine. It's because, again, they're being prone and being restrained.
Thank you. And we are about out of time for today. So thank you again, everyone, for joining us. And just a reminder, we will be sending out an email with the CE information. And Sarah just posted it in the chat also. And we thank you again, and everyone have a good afternoon.